Recording in progress.
We're all set, Ilya, if you want to begin.
Great. Thank you, Catherine. And thank you to Thorncrest for the opportunity to be here today virtually to talk with you about COVID-19. We are really fortunate to have two of our local providers in Albert Lea and Austin with you to share some information about COVID and, most importantly, answer your questions. We are recording this session so that others will be able to watch it after the fact, and we'll share it with some other long-term care facilities. Before we get started with the presentation, I'd first like to introduce our panelists. Dr. Sumit Bhagra is the newly named site lead physician for Mayo Clinic Health System in Albert Lea and Austin. He is an endocrinologist and specializes in diabetes and metabolism. He went to medical school at All India Institute of Medical Sciences in New Delhi, India, did his residency in internal medicine at Mayo Clinic in Rochester, and a fellowship in the Division of Endocrinology at Mayo Clinic, Rochester. As I mentioned, he has a special interest in diabetes, obesity, metabolism, and other hormonal conditions. Heidi Gaston is another beloved local provider. Heidi is in the Obstetrics and Gynecology department and also works with our family birthplace and the pre and postnatal care. She attended medical school at Kirksville College of Osteopathic Medicine in Kirksville, Missouri, and did her residency at Genesis Regional Medical Center in Grand Blanc, Michigan. She has special interest in adolescent health, general OB/GYN, infertility evaluation and treatment, and other women's health needs. So again, we're delighted that they could be with us today, and we'll have a short presentation and then open it up for questions. And those of you who are watching via the Zoom, we encourage you to use the Q&A feature, and questions will be submitted from those of you together at Thorncrest. Catherine will type them into the Q&A and we'll read them to our panelists to answer. And I just should note, Dr. Gaston let us know that she would love to have her video on, but she is at a computer that doesn't have a camera. So we'll just be seeing her name, but she is indeed there behind the screen. So with that, Dr. Bhagra, I will turn it to you.
Thank you so much for having us over and the chance to present some data. What the pandemic has really made clear to us is that we are all connected, and what happens sometimes thousands of miles away is in our backyard within a few days. So building on that theme, Mayo Clinic, the hospital, and all the facilities that exist for schools, we used to work in silos and we thought of those as different entities doing the job. But our common goal is, one, the needs of the patient come first, and all of us truly want what's best for us and for our communities, and no one intentionally wants to harm the other person. There is a lot of information and misinformation about vaccines, masking. People really don't know who to trust or what sources to go to. So I'm going to present the medical data that we have in a way that's easy to understand. And I also understand that there's lots of people who are yet on the fence about getting the vaccine or don't really know who to trust. And the decision for them is a difficult one at this point in time. I think the key is not to hold any judgment against people you know who might not be vaccinated, but just to try and understand where they're coming from and trying to understand their concerns and provide the best data that we have available to help those people in this grave dilemma being able to make the right decision. So we're going to talk about the fourth surge and the so-called Delta variant of SARS-CoV-2, the virus which causes COVID-19 disease. Talk about the vaccines we have available, some of the other preventive measures that we had talked about prior to vaccines becoming available. Those measures are still very effective. With the vaccines, the ability to prevent COVID-19 disease, in fact, goes up a few notches. But we're not saying vaccines substitute for social distancing or masking. They all work together. And we'll provide some more information as well. I'd like to start with a disclaimer that this information is not medical advice to the individual. Many patients or many people might have questions of a personal nature that relate to the diseases they have, or questions that are very unique to their circumstances. We're not attempting to answer your individual questions because they are best answered by your primary care provider. So Dr. Gaston and I will provide the information we have from a general perspective, try to answer some questions that may have general applicability, but for unique circumstances or individual concerns, we would refer you back to your primary care provider to have those questions fully answered for you. Next slide, please. So the Delta variant, we started out with the Alpha variant, which over time became the Delta variant, much more transmissible, nearly 225% more transmissible, meaning it can infect up to twice as many people. And in some instances, people are further than 6 feet away, or they really didn't think they were exposed, but they get it from people that might have been distant from them, or they went to a crowded place. They were wearing a mask, but there was, the viral load was so much that their systems got overwhelmed. So much more transmissible. It causes much more severe disease compared to the original virus we had, and a greater likelihood of hospitalization, especially among the younger people who are unvaccinated. The risk of severe illness defined by needing ICU care or intubation, being attached to a breathing machine, is 5 to 10 times higher among the unvaccinated as we see it today compared to the vaccinated individuals. In fact, as we speak today, most of Mayo facilities in the Midwest are full. ICUs are at capacity. Emergency departments have been very busy. In some cases, hospitals around us have had to pause elective surgeries. I've heard of Minneapolis-based systems that are no longer doing purely elective surgeries. Mayo, fortunately, is not in that situation today, but the Austin Albert Lee Hospital did have to pause elective surgeries 6 to 8 weeks ago for a few days to tide over a pretty tight time in our operations. Mayo Clinic continues to provide evidence-based information about masking, vaccines, quarantining, not just to local facilities, but to local school districts, city governments, and any entity that has questions about and does not know where to proceed when given different sources of data. Next slide, please. So hotspots in the United States. As of today, many might have heard in the news that Minnesota is currently leading the nation in the number of cases per 100,000. And the darker the colors that you see on the screen, the higher the case rate. Minnesota, along with Michigan, is among one of the highest rates in the country. You may have recalled that last year we had mostly the coasts and the large cities impacted. And as the COVID-19 pandemic has made its way into the Midwest, it's largely the smaller communities that are more impacted than some of the large cities. There are many reasons for that. Among them is laxity in masking and some safety precautions. Because if you look back a year, when the lockdown happened across the country, some of the smaller places were not that impacted, and the lockdown was felt to be perhaps too much being done for too little. Now that the smaller communities are impacted, and as you can see on the Minnesota map, it's some of those less densely populated counties that show the darker colors. Folks are still living in the sort of mindset of a year ago that this is not something that's impacting smaller communities. And as they go around their day without masks or perhaps not maintaining social distancing, large gatherings, sporting events, etc., it is the smaller rural counties that are disproportionately impacted in terms of number of cases. What makes it worse is that the vaccination rate, generally speaking, tends to be in the 50 to 60% range. And in the past, we've talked about reaching that 60, 70% magical range to reach herd immunity. But that number really applies to the original variant of the virus. As the virus became much more transmissible, the 50, 60, or 70% is no longer thought to be adequate to attain herd immunity. So while we have half or more of our population vaccinated, the number of cases are going up. Minnesota is the top hotspot in the country. And in some instances, the number of cases being hospitalized or detected are higher today than they were back in May or June of 2020. Next slide, please. Our positivity rate in Southeast Minnesota across all our Mayo facilities, which includes Owatonna, Red Wing, Cannon Falls, Lake City, etc., ranges between 15 and 25% over the past several weeks. 10% for reference is considered to be a very high number. We've been double that on many days for the past 1 month. Next slide, please. Our overall numbers of cases across the surrounding counties remains really high as well. As you can see, around June or July, we had our lowest numbers. And for a while, people felt that, the summer was here. July 4th was to be a holiday where everybody could celebrate. Shortly after that, with the emergence of the Delta virus, we've had cases go up, they plateaued, came down some, and again, the numbers continue to rise. And we're not sure when that plateau or the spike will let up a little bit and allow us to get back to normal. Next slide, please. So vaccination, obviously very effective in preventing severe disease. And we don't know what the magic number is to get to when the pandemic takes a breather, but we feel that number is probably 85, 90% or greater. As you look at Freeborn County, we've got 54% of overall population vaccinated who've completed the vaccine series. So either received 2 of the Moderna or Pfizer vaccines or 1 of the Johnson & Johnson. As you look at the various age groups to the bottom right, the first bar shows 6% of 5 to 11-year-olds vaccinated. Of course, this is recent data and the vaccine just got approved. So we've only had 6% of kids vaccinated. That rate is about 40-45% among the 12 to 15-year-olds. The rates are not very different in the 16 to 17 age group versus the 18 to 49. So the uptake of the vaccine remains pretty low, with half or less of the people vaccinated in those age groups. As you go to the age group of 50 to 64, the numbers are high, but they're not as high as some of the other counties. We've seen numbers as high as 80% in this age group. In other counties, 65 and older, we get to 90, 95%. And thankfully, that's preventing a lot of mortality in this group. In Freeborn County, however, we only have 88% who've received 1 vaccine, or 85% who've been fully vaccinated in the 65 and older age group. As we know, we have a lot of 80, 90, 100-year-olds living in Freeborn County, thanks to the healthy lifestyle and the people that populate Freeborn County. So to have an 85% vaccination rate in people who might be 70, 80, 90 years old does expose the unvaccinated to a grave risk of severe disease and the risk of dying. Next slide, please. So COVID-19 vaccine, we are fortunate to have 3 different vaccines available to us. The Pfizer has full FDA approval. Moderna and Johnson & Johnson are under EUA. Moderna is in advanced stages of getting full FDA approval. Johnson & Johnson plans to apply for full FDA approval later this year. They had planned towards the end of the year. I'm not sure where their application is in this process. I shudder to think if we did not have any of these vaccines available today, if you look back at the polio pandemic or epidemic, we did not have a vaccine for more than 10 years. And there were hundreds of thousands of people affected that still bear the consequences of poliomyelitis. On one hand, we are fortunate to have a highly advanced scientific community that came together to get these vaccines ready. On the other hand, the rapid rollout of the vaccine also raises question in people's mind, in lay people's mind, as to how the vaccines could be devised so soon. Was enough research done? Are they truly effective and safe? So it does raise concerns when a vaccine is available within a year of finding a new disease. Fortunately, Pfizer, Moderna, Johnson & Johnson are highly effective against the Delta variant as well, although Delta does tend to escape vaccination more so than the Alpha variant. They are not 100% effective. And if you see somebody who's vaccinated who gets COVID infection, that is not proof that the vaccines don't work. If you look at the hospitalized patients, especially the ICU patients, you would find less than 5% of patients in the ICU who are vaccinated. So really the vaccines prevent severe disease. They prevent people from being in the ICU from COVID-19, and they prevent the risk of dying from COVID-19. Patients who've been vaccinated can get infected, especially because after getting the vaccine, some of the individuals feel that they have protection and may engage in behaviors that expose them repeatedly to COVID-19, the agent that causes COVID-19. Third doses are necessary for people with immunocompromised states. So if you've been exposed to chemotherapy recently, certain types of diseases, certain types of drugs, there's also boosters available for specific populations, so above age 65, adults with certain medical conditions, or people that work in occupations that result in frequent repeated exposure to COVID-19. This morning, boosters were approved by the FDA for all adults, but that decision still needs the stamp from the CDC to become ready for implementation across the country. So the risk-benefit analysis of getting the vaccine, it is not to prevent any disease from occurring, but it decreases the likelihood of being hospitalized or dying from the disease by 5 to 10-fold. It does make transmission less likely. So if a person is vaccinated and does find themselves in a situation where they did get infected, they would shed the virus for a shorter period of time and perhaps reduce the number of people around them who get infected from them. Additionally, because there's less infection going around, there is less cross-mixing of the viruses. It is the cross-mixing that results in different variants emerging. So the less spread of the infection we have, the less likely we are to create strains in the future that might potentially escape vaccine protection as well. Next slide, please. So on the lay media and among health professionals, it is natural to ask questions about concerns related to fertility, pregnancy, other autoimmune conditions, and those questions are legitimate. Dr. Heidi Gaston, are you still on the call? I know you're on call as well and might have to step away.
Yep, I'm here.
Could you speak to how you counsel your patients who are either considering a pregnancy, currently pregnant, or breastfeeding, and how that relates to getting the COVID-19 vaccine?
Yeah, so at this time, the COVID vaccine is recommended for all pregnant, breastfeeding, or women who are interested in getting pregnant women. So that recommendation is supported by ACOG, which is the American College of OBGYNs. They are the governing body that makes all of the recommendations for how a pregnancy should be managed in the United States and have been so for many, many years. It is also recommended by the Society of Maternal Fetal Medicine, which is the society that specifically deals with high-risk conditions of pregnancy, whether it's a maternal issue or a fetal issue. So we have the recommendation and stamp of approval from the highest bodies of medical committees that research, study, and know this population in and out and have medical research to support their recommendations. Based on the data from the trials and now real life use of the vaccines, there have been no increased adverse effects with pregnancy, fertility, or breastfeeding. So any adverse outcomes of those types of situations like miscarriage, preterm delivery, high blood pressure, pregnancy, none of those issues are more common in women who have had the vaccination. Additionally, because pregnancy is an immunocompromised state, those women that are exposed to COVID-19 infection are somewhat more likely to get the infection than their counterpart, similarly healthy individual. And if they do get the infection, they are more likely to have a serious infection than, again, their non-pregnant counterparts.
Thank you. And on the next slide, there is some data about the post-vaccination adverse events from pregnant people as reported to the database. And we had 121,000 pregnant people vaccinated in the USA as of May 28th. The small orange section of that pie represents any adverse events reported, a total of 1299. 600 of those were common mild reactions, 330 miscarriages. The other side effects were much less common. But if you were to compare those to pregnancies that occurred without a vaccination, these rates are not any higher. In fact, unvaccinated individuals who are pregnant, as Dr. Gaston mentioned, when they develop COVID-19, the disease, they are much more likely to end up in the hospital and require emergency type care. In fact, if you were to look at any possible outcome, any hypothetical outcome, it is more likely to occur in a COVID-19 infection setting than in the setting of having received the COVID-19 vaccine itself. The mRNA-based COVID-19 vaccines contain just the spike protein. So they present something to the body which makes the body believe that infection is present. So the body mounts a response to fight off an infection that does not exist. So you can get the protection of having been infected as if you were infected without getting the infection. So you've got the protection with some body aches, fevers, common type of side effects for a few days after you get the vaccine, minus the virus, minus the lung damage, minus the risk of ending up in the ICU. Mayo Clinic physicians, nearly 99% of those have been vaccinated. And we still have them working at the Mayo Clinic. It's not like they were, sick or had to not report to work or disabled because of that. We've not had any absences long-term related to the vaccine. I do have some anecdotes of just a handful of people I know that have had to either leave work or go on disability from COVID-19 consequences because they got infected. So really it's about looking at the data, and you can always look at the exception and say, well, what about the person who got vaccinated and got the disease? Well, that's an exception. Those things do occur. But there's also many people who got infected and ended up with consequences that prevented them from doing the job they were trained to do. And that obviously has a lifelong consequence on themselves and their family members as well. Dr. Gaston, anything to add regarding the pregnancy slide here? Because I know you're the expert in this area.
Oh, this is great. And this is exactly the type of data that our societies are evaluating as they continue to make those recommendations.
So we'll move on because we'll have questions at the very end, right, Ilya? Perfect. So the other question people ask is, why do vaccinated people still need to wear a mask? Wasn't the whole point of getting the vaccine to be free of this thing on your face and be able to live life normally? So if enough people got vaccinated and the Delta did not emerge, it is possible that we would have been living lives as close to normal as possible today. But because we don't have the level of vaccination needed to attain herd immunity, and because the virus mutated to a much more transmissible variant, it is possible for vaccinated individuals to become infected. Fortunately, vaccinated people develop very mild symptoms or no symptoms at all. So when taking care of patients who might be immunocompromised or patients in general, it is possible for a healthcare worker to come to work feeling absolutely fine and still be carrying the virus in their body and possibly transmit it to the other person. So patients are asked to mask, And providers, nurses, other people working in the hospital are asked to mask as well. Vaccinated people can spread COVID to others, although it appears that the risk of transmission is slightly lower than getting it from an unvaccinated person because of the number of viral particles in their nose and mouth and how dense the fumes, if you will, from their body are that infect the other person. So masking is still required in indoor places, especially indoor places with poor ventilation, and in some highly crowded outdoor places as well. In fact, when counties and states become, the dark red color we showed, the purple color or whatever, it may be recommended to have a mask on even in the outdoor setting, especially if there are lots of other people that you don't know in the same area. So places like grocery stores, when you're in the state of Minnesota and the numbers are that high, highly recommended to have a mask on regardless of vaccination status. Next slide, please. So here is what we know so far that works to reduce spread. And if you look at the process of spreading, it is really from person to person. The surface transmission is not that important in causing infection. So early on in the pandemic, we would clean our doorknobs very, faithfully, sort of scrub them. People would wash hands obsessively, dozens of times a day. We know that the highest density of viable virus, which can possibly infect another person, occurs when a person breathes very close to you, speaks very close to you, sings very close to you, or eats food in your close proximity. So maintaining distancing, very important. Having a mask on, important in reducing the risk of the number of particles floating around a person. A recent study showed that masking does decrease the risk of infection by approximately 55%. Vaccinations reduced the risk of infection by 91% in some of the early studies. But as you look at real world data, meaning people vaccinated and then they go about with their lives without a mask and perhaps engage in social activities, the real world efficacy may be 60, 70, 80%. So under ideal conditions, vaccines are very effective, but really it depends on what humans are doing in their time that may expose them to the virus and cause breakthrough infections as well. So when vaccines fail, it's partly the 9% non-effectiveness of the vaccine. And a large portion is what people do when they get vaccinated and get this sense of invincibility, where they might engage in behaviors that exposes them to the virus. Hand hygiene, very important. So if you've been, touching doors at a gas station, grocery shopping, make sure you don't touch your face and nose, and then wash hands as soon as you get back home before consuming food, etc. Testing when symptomatic remains very important, and isolating when sick, even if you don't know whether it's COVID or not, is important until the results come back. So if all these measures are taken, you can reduce the risk to yourself, your loved ones, and people around you. There is no one magic bullet. Every intervention shown here reduces the risk by 30, 40, 50, 70, 80%. Together, they can be highly effective. Next slide, please. So vaccine appointments are available at the vaccine clinic or after a medical appointment. The medical appointment vaccine is only given if supplies are available for that day. Appointments can be made at the vaccine clinic by calling the number shown on the screen, self-scheduling using the patient online service or the Mayo portal. Anybody under the age of 18 that needs to have a vaccine needs to have a parent or a guardian who can sign consent for them. And for other locations in your community, visit the Minnesota government website. And there's other, Walgreens local stores that might give the vaccine listed there as well. Next slide. So this is the Mayo Clinic Health System website, a trusted resource for all information, especially COVID. It's updated frequently and provides information in easy to understand language for lay people who might log on to find out more. There are other resources as well, the Mayo Clinic Health System blog. Next slide, please. And I think that concludes our presentation, and we'll open it up for questions. Thankfully have at least half hour for questions.
Great. Thank you, Dr. Bhagra and Dr. Gaston, for going through some of the basic points just to kind of level set. And Catherine will submit some questions from Thorncrest via the Q&A, and anyone else listening on the webinar is welcome to use the Q&A feature to submit questions. We did have some questions submitted prior to the beginning, so why don't I start with those as other questions are posted. Dr. Gaston, maybe back to you. We did talk a little bit about pregnancy and the vaccine when someone is already pregnant, but what about the issues of people who are thinking of becoming pregnant and how it impacts fertility? And then more broadly speaking, how does the vaccine affect a menstrual and ovulation cycles, especially for someone who's been working on trying to manage that for many years?
Good news is it doesn't seem to impact our menstrual cycle at all. So whether you are somebody who has a normal, incredibly predictable textbook cycle every 28 days, or if you are somebody who has needed medication and interventions and lots of testing to figure out why that hasn't been your normal along the way, this intervention should not impact your menstrual cycle currently. So by not impacting our menstrual cycle or our hormonal values, it is also not going to impact ovulation. And because of that lack of impact, it should not significantly or at all impact your ability to conceive compared to your pre-vaccination status. So if you were somebody who was likely going to get pregnant with attempts at conception, you will still likely get pregnant with attempts at conception. And if you were having difficulty for one reason or another, this is not an infertility treatment. It is not meant to take the place of a medical consultation for solving that problem of infertility.
And maybe, oh, sorry, Dr. Bhagra, please.
I would only add that none of the previous vaccines, and I realize none of the previous vaccines were mRNA vaccines. So looking at measles, mumps, other vaccines given to children have been associated with infertility per se. In fact, the mumps vaccine protects the dreaded complication of testicular inflammation and might preserve fertility in boys when they get the mumps vaccine. So long track record of vaccines in general being safe for fertility. And perhaps one example of a vaccine that protects the reproductive organs in boys. It might be true in girls as well, but I'm not sure how frequent mumps caused ovarian inflammation for girls. So not concerned based on the data that we have so far that there's any relation between fertility, reproductive function, ovarian or testicular function after the COVID-19 vaccine. Go ahead, Heidi.
Great. Well, that was actually going to be my question, is fertility issues for men, but thank you for answering that. But on the point of inflammation, what is the possibility of the vaccine causing inflammation? And another way to ask the question, is there a guarantee it won't cause inflammation?
I'm sorry, Ilya, are we speaking specifically of like inflammation in the arm, the site of the injection, or more specifically inflammation of the ovaries or uterus or something like that?
I don't think it's specific to reproductive organs, but perhaps just general inflammation when in the arm, but also overall systemic in your whole body. Does the vaccine cause inflammation? And this may be related to other concerns about things that people have heard in terms of issues with blood clotting, impact on migraines, other medical conditions that the vaccine can impact.
So I'll take this one. You know, the word inflammation is really the body's immune system trying to fight off something. So when you get injured, bump your arm into, say, a door handle and it becomes red, painful for a few days, that is inflammation. Technically, when you give a vaccine and the body tries to fight it, it is part of the helpful inflammatory response to develop an immune response to that. So people use the word inflammation very broadly. We don't expect it to trigger long-term inflammatory consequences, but there is a cycle of events that occurs in the body for the first 1 or 2 days as the body makes antibodies and calls the white cells over to make one the antibody and create some cells that remember what COVID-19 particles look like, so they may fight infection when they next see it. So from a textbook perspective, there is 1 or 2 days of inflammation, and that leads to the body aches, the fever, etc. In fact, anytime you have a fever, you likely have inflammation going on inside the body, but it's self-limited. So the vaccine, any vaccine, will cause self-limited inflammation, but it does not set into motion inflammatory disorders in general. People that have those disorders might have exacerbations from time to time anyway, and it's very hard to know if there's any causal relationship between the vaccine given to you, say 5 or 6 days ago, and a migraine that occurs a few days later, because people who've not got the vaccine will have migraines, once a month or several times a year. So it's hard to make those connections, but you can always find anecdotal reports of people on social media claiming that you got the vaccine and 7 days later, something else happened. If you look at thousands of people, we don't find a signal that any disorders or diseases are more common. On the point of the blood clot, the Johnson & Johnson vaccine causes a few people in a million to develop a rare type of blood clot. Those were typically younger women. I don't know if birth control or taking birth control was one of the confounding factors there. So for somebody who's concerned about blood clots, we do nudge them away from the Johnson & Johnson vaccine and perhaps consider the Pfizer or Moderna vaccines. So long answer, but some of these terms get thrown around on lay media, social media. So I just wanted to clarify that here.
Well, that's actually a great lead in to another question that we got, which is what vaccine do you recommend, in this case, between Pfizer or Moderna, based on lesser side effects and reactions, and why? I guess the more broad question is, do you typically recommend one vaccine over the other?
So my response to that is any vaccine is better than no vaccine. And if you're going to have to wait a month to get your desired brand, I would rather get what's available. Other than the blood clot concerns, if somebody is truly concerned or has a family history of or a personal history of, they might want to choose between Pfizer and Moderna, but all three are available. Pfizer is fully approved, and people can really pick from the menu as to what's available or what they'd like to have. But Mayo does not recommend one over the other. They're all equally effective and equally safe.
And I will just put a plug in on the website at mayoclinichealthsystem.org under the COVID-19 vaccine page. There are links to the vaccine documents, which list the ingredients and all the information that the FDA requires providers to publish for patients. So it's accessible that way. But speaking of reactions, if you have a relative who had an allergic reaction to the vaccine, what are the chances that you might have a reaction to that? And then a follow-up for Dr. Gaston on if you are pregnant in that scenario, if you have a reaction to the vaccine, will it have any impact on your pregnancy?
So the first question, again, I have incomplete data to answer that question. Depends on how close that relative is to you and what type of reaction they had, and did they have it to the exact COVID-19 vaccine or vaccines in general. But overall, if you're concerned about a potential allergic reaction, I'd say get it in a hospital type setting, so at a medical center as opposed to a freestanding clinic, so that they'd observe you for 15 or so minutes. Most reactions occur within 15 to 30 minutes of getting the injection. If that were to happen and it's a weekday in a larger medical center setting, you'd be able to access help within a few minutes if you need it. Just personally speaking, I recommend that patients not get it on a Friday, 7 p.m. at a local Walgreens right before closing time, because if they do have some concerns, their only recourse would be to end up in an ER or urgent care. So plan your vaccination date according to your concerns and talk to your primary care provider about if you've had anaphylaxis or food allergies that are very severe, then it might be a conversation between your provider and yourself to mitigate the risk of potential complications rather than say that the vaccine is not something that would work for you. The benefits of the vaccine still outweigh potential risks of allergic reactions as long as it's taken at the right time, at the right place, and any eventuality can be addressed by medical professionals available around you. So a medical center kind of makes sense in that situation. Just a common sense. I don't think that's in any recommendations or guidebooks out there, but that's how it practically managed that situation.
Right, thank you. And Dr. Gaston, with the follow-up question of if you are pregnant and have a reaction, what impact does that have?
Thanks for the question. So we have not seen that any reaction to a pregnant mother impacts the fetus. Similar to a non-pregnant person, if an adult had a reaction to the vaccine, they would primarily do supportive care. But if the home supportive care was inadequate or they did have concerns, they would obviously want to have some kind of hospital evaluation. And we recommend our pregnant women have hospital evaluation with any concern that they have as their pregnancy progresses. So if they were experiencing abdominal pain or decreased fetal movement at any time of their pregnancy, regardless of their vaccination status, we would want to evaluate that.
Great, thank you. At this point in the pandemic, almost 2 years running, there are a number of people who have had COVID along the way, or think that, they know of people who had COVID and it wasn't that bad. So they sort of assume that if they get it, the natural immunity will kick in. Could you talk a little bit about natural immunity from getting exposed to COVID versus having the vaccine?
Yes, I'd be happy to take that. So some infections have a natural immunity that lasts nearly lifelong. So if you get chickenpox, you're highly unlikely to get it again because it lives inside your body and the immune system learns to live with it. And a new disease is highly unlikely unless you become immunocompromised again. When people grow older, they develop zoster, which is a type of chickenpox reactivation. Unfortunately for COVID-19 virus, protection is not lifelong. It appears it's not even 1 year long. Most cases that have the COVID-19 infection per se are susceptible to infection within 90 or so days of getting infected. I've seen a patient who's had it twice. I've heard of a patient who's had COVID 3 times. So if 3 to 6 months is the time frame, this person was unfortunate enough to develop it 3 times over an 18-month period. Vaccine-related immunity tends to be more robust, higher antibody levels, longer lasting. And we thought that it would last a year or longer, but it turns out that the length of protection is probably 9 months for many people. So it is possible to start getting infected if you took a large cohort of people who were vaccinated. You would start seeing the first signs of people getting infected right around that 6 to 9 month mark. Some of the countries undergoing resurgences today, such as UK and Israel, they vaccinated a large group of people at the same time, 90+% vaccination rates, and all of them immune initially, and immunity is now waning, hence the need for boosters. So to answer the question, COVID-19 infection immunity is not lifelong. It is not even a year long. It's probably 90 days, slightly longer. It is advisable to get the vaccine after getting infected within 60 to 90 days to boost the level of immunity so that it may last many more months. It's still an evolving field. Boosters seem to restore immunity. We don't know if they'll need to be boosted again, whether it's a year later, 2 years later, 5 years later. But it's an evolving field. It's a threat that humanity has never faced together. So that nothing like this has ever been around in the past 50 some years. Science changes, the data changes. We look at the emerging data. We've got research going on every country across the world. And we learn from the data that emerges from other countries as well, so that we might not repeat the mistakes that the other country did. So there's a lot of talk about why not vaccinate the whole world before giving boosters to the more developed nations. But we do have a supply available and we do have cases going up. So it makes sense to get the vaccine, even if you've been infected in the past. And if you've been vaccinated, to consider boosters to maintain your protection through this, because there's a lot of people who've received the vaccine 6+ months ago who've had mild cases of COVID-19. Now, their infection might be mild, but they might be taking care of children who are 5 years old, meeting grandparents or parents through the holiday season. Their mild infection might translate to a very severe infection for somebody they see through the holiday season. So again, a long answer, but vaccines still work for people who've been infected in the recent past.
And if you've had a COVID infection and then you get a vaccine, what are your chances of having a reaction that is different than what someone who's just getting the vaccine would be?
So what we do know is that the vaccine itself, if given to somebody who's never been infected, elicits an antibody response, and the second shot has a much stronger antibody response. It is conceivable that a person who's been infected recently gets the first shot of the vaccine and their immune system, the antibodies go up really fast, robust immunity. They might have short limited side effects from the first shot. There is no guidelines for people who've been infected recently to state that they should just get the first shot and be done with it. But it's conceivable that the first dose in a person who's been infected might be very effective. And the second dose may actually build immunity to levels that protects them for longer and much stronger. But you're absolutely right. If you've been infected recently, the first dose may elicit a very strong antibody response. And that may sometimes result in more body aches, fever, etc. But that's not clinically significant in that people are not laid up for weeks or months. It's probably a day or two longer than other people, or slightly more likelihood of developing those types of side effects.
Great, thank you. We have a couple more questions that have come in from the chat, and this one I'm not sure we're going to be able to answer it, but I'll throw it out there. Why is it necessary to sign a release of liability if the pharmaceutical companies are confident if the vaccines, probably of the vaccine safety?
I don't know the answer to that question from a legal or a technical perspective, but it's for the same reason that a surgeon has people sign a consent form saying that, if a complication were to occur, or sort of signing away to say, we understand there could be blood loss or other things. I understand surgery is way different than getting a shot. But there are rare side effects, things that affect 1 in a million people. The blood clots that occurred in Johnson & Johnson was, 4 to 7 in a million people. So those rare side effects do uncover themselves with time. I'm not sure if a legal or the technical basis for why that consent or release is signed anytime a vaccine is given. It's probably done for all vaccines, not just the COVID-19 vaccine.
I do recall as a parent of young kids, I used to have to sign whenever my sons were getting vaccinated, but it's been a long time. So, but yeah. That's a good lead into this next question. Can adverse events occur years after vaccination?
That is highly unlikely, although knowing that the first trials were done November, we had approval for the vaccine last year. So the trials were probably done 6 months prior to that. The data is about 18 months long. And had the pandemic not been the serious tragedy that humanity was facing, it's possible that the trials would have run for slightly longer. But there was a need, there was a collective human disaster going on across the world at the same time. But it's highly unlikely that if a person were to withstand the vaccine and have just self-limited side effects, that somebody would develop a rare side effect 5 years down the road, 15 years down the road. Because at that point in time, the mRNA injected results in antibody production. The actual mRNA itself is degraded within minutes or days. I can't remember the actual degradation time. But the stuff injected is no longer there. It's just your own antibodies and your own B and T cells that kind of recollect what COVID-19 looks like. It retains a memory of it. And the next time you see the virus, the cells go into overdrive and sort of kill the virus before it infects you. So from a physiologic or medical standpoint, it seems highly unlikely that an injection given today would have side effects 10 years down the road if you weren't immediately impacted by short-term side effects.
I'll put another plug in for the Hometown Health blog and at the mayoclinic.org COVID-19 page, where there are a number of articles and frequently asked questions where some of your questions that you have might be able to be answered as well.
Ilya, I would just add that the COVID-19 infection itself, from what we know over the past 18 months, there have been many cases that you might have seen on social media, newspapers, with muscle loss, debility, deconditioning, heart failure, heart attacks, not even touching upon the people that died, did not have long-term consequences, but they're no longer alive to face those consequences. People who cannot breathe, people on oxygen dependence, etc. So you really have to weigh the risks and benefits of COVID-19, the disease itself, and a sizable proportion of people who end up with severe side effects, and a much larger group that has subtle side effects called the long COVID syndrome. So things like brain fog, cognitive effects, not being able to work in certain highly cognitive jobs because the brain doesn't seem to be working well. And we don't know why that is, but it could be from brain connections sort of going haywire. So if you look at the COVID-19 long effects, you'll probably find thousands of references of things and people affected. But so far over the 18 months that we've had the vaccine, 12 months actually for the vaccine, we don't have any long-term consequences from the vaccine. People self-report their side effects, as well as an app. Is it called vSafe, Ilya? It's a vSafe website or a vSafe app where people can download the app and actually report any adverse events they've experienced back to a central database as well. And so far, the database does not contain any signal that the vaccines are dangerous. Otherwise, the surveillance mechanisms would have pulled the vaccines or at least restricted their use. They've gone through the peer review process. They've gone through research trials. They've shown to be effective. And so far, what we know, they seem to be extremely safe as well.
And just to clarify, the COVID-19 long haul and the long haul syndrome comes from people who have been infected with COVID-19 prior to vaccination. It's not a result of the vaccine.
That is correct, Ilya.
Okay, right. We've got one more question in the queue. If anyone else, we are also coming up to the top of the hour. So this is the last call for questions, but let me ask this one. Can the vaccine reverse a remission of an autoimmune disease?
I would have to defer to, it's a very focused question. After you get the vaccine, there are some changes in the immune system. There could be anecdotal evidences of people who got the vaccine and had, say, a disease, Graves' disease, thyroid problems, worsen. It's hard to make the causal relationship. But I would say we'd have to do more research into that specific question to provide a more specific answer, because I understand this is being recorded, and I don't have a direct yes or no answer to that question.
Okay.
It does affect the immune system in general by making the antibodies, and some people prone to autoimmune conditions have rare things happen to them that would be best understood by rheumatology or immunology. So if concerned about the recurrence of a disease that's currently under remission, I would consult with the specialist that sees you for it to get a proper answer.
Great, thank you. And we can follow up with anybody who's got a specific question. We can try to get you some more information if you'd like. All right, so again, thank you to Dr. Bhagra and Dr. Gaston. Maybe as we wrap up, I'll let you both have some closing remarks. And in the spirit of what we've been talking about today, if you were walking down the street with your mask on and someone came up to you and said, hey, I haven't gotten that vaccine thing yet, what do you think? What would you say to them? Dr. Gaston, I'll let you go first.
I would highly encourage them to proceed with the vaccination. This is a question that comes up very regularly in my practice, but I've certainly had plenty of people text me or ask me, just for your personal and professional opinion, what are your thoughts about this? And I am supportive in both regards and feel very safe in making that recommendation to you.
Excellent, thank you. And Dr. Bhagra?
I would only add that, everybody who works in healthcare and outside of healthcare has worked really hard. We know everybody's short-staffed. People are probably doing 1.2 FTE work for the job they signed up for. It's been challenging from a personal safety perspective. I'm sure the people who haven't gotten vaccinated yet, it's not because they don't want to get vaccinated. They want to be safe, and they have genuine concerns about the safety efficacy of the vaccine. So if somebody asked me the question, I would first of all not judge them. I would try to understand what they've heard. And if I had an hour, I would sit down with them, have some coffee, socially distance, of course, and keep my mask on while drinking coffee. I'm not sure how you do that. And try to understand as to what the genesis of their understanding is and try to clear some of those things up. Concerns are legitimate. People have concerns, they're real for them. It's possible that 95% of people don't understand why people have concerns, but for the people that do, those concerns are real. And you've done a fantastic job taking care of people in the profession you chose. And it is a noble profession. It is worthy of pursuing. When people come to us for care, they expect that we would not be the ones infecting them. That's, the do no harm principle. We don't expect healthcare providers to harm somebody. And by not adopting an intervention that's so far been proven to be successful in preventing the infection and transmission, we are perhaps losing sight of the do no harm principle, at least in the jobs we do. So that's all I'd say, Ilya. Great job to all healthcare workers, everybody else who's helped run the world through these terrible 18 months.
Indeed. And yeah, we want to extend a special thank you to all of the employees and staff of the long-term care facilities throughout Southeast Minnesota and beyond, who have been our partners in managing these difficult months and taking care of the people that we care about in our communities. So thank you for that. And thank you for hosting today. The webinar will be made available by recording. And if you have other questions, we would be happy to field them by email and get back to you with some specific answers. But again, probably the best advice is to contact your care provider for your individual advice. And with that, Catherine, any other closing remarks from Thorncrest?
Nothing here, but thank you so much. We really appreciate your assistance.
Thank you.
Thank you for having us.
Thanks, everyone.
Thank you.